All right, so we're going to get started here, folks. My talk is called Veterans Health, and we're going to be covering some of the national trends in veterans health, barrier to access, and some unique considerations when providing care to combat veterans specifically. My talk is going to focus more on Iraq and Afghanistan veterans, just in the wars over the last 20 years. I can speak to that more from my own personal experience as well. Although some of the data that I'll talk about does include Vietnam era veterans. We just have the most of the new data is focusing on the most recent wars. So I'm gonna get going here. All right, so almost 3 million Americans have served in either Iraq or Afghanistan at this point. Almost half of them have been deployed multiple times, and that's been shown to be a risk factor for PTSD, is multiple deployments. Nearly 1 million of them have service-connected disabilities, but there are probably many more that have fallen through the cracks, given that only approximately a third of veterans do have a service-connected disability. This is a picture of some folks from my platoon. You can spot me in the back. That's me right there. And this is us all hanging out in a little bunker when our base was getting a rocket or a mortar attack. So we still had pretty good spirits in there for the picture, given the circumstances. Some of the challenges that are faced by returning veterans are PTSD, moral injury, traumatic brain injury. Those are going to be the three main topics that we're going to focus on today, but we'll touch on everything that's on the list there. So why did I join the military? A lot of folks have different reasons for joining the military. Some of them, feel a call to serve, given, whatever the climate of the situation in society is at the time. Some want to get college paid for, some want to travel the world, some just want to get out of their hometown. There's many different reasons why folks join the military. So one of the recurring themes throughout my presentation is going to be that there's not really a one size fits all answer for dealing with veterans, especially when you're dealing with veterans from different war eras. You kind of have to take everything on a case by case basis, but there are some general rules of thumb that I think can be helpful. So for my reason, I have a pretty strong family history of military service. This is a picture of my father here. He served in World War II, and he was one of the Tuskegee Airmen. For those that are familiar, you can see on his discharge statement here, it was signed by Colonel Benjamin O. Davis. He was the commanding officer of the Tuskegee Airmen. And I'm going to go to this next picture here that has a little bit more information. The unit was famous for being the first Black pilots in the military. This was at the time when they were just starting to desegregate. And a lot of folks at the time didn't think that the African Americans were able to fly planes for a number of reasons, but they proved everybody wrong. This is, let's get back here. This is Colonel Benjamin O. Davis. He eventually retired as the first Black four-star general in the Air Force. So just was breaking barriers the whole way through his career. This is a photo of my father here on the left as part of this is his flight crew. He was an enlisted bomber navigator. And then one of the famous red tail P-51 Mustangs they have up there. So a lot of cool history there that, if you're not familiar with it, I recommend reading about them or watching a documentary. There's some good stuff up there. I just thought that this, they made some new quarters last year or a couple of years ago. And I thought one of the cool descriptions on there was they fought 2 wars because they, really were volunteering to serve in, to represent a country that, wasn't really showing them the same type of love and support back home. So they were kind of faced, on 2 fronts with some difficulties there. But pretty amazing story for these guys. So my dad continued to break barriers. He went on to do a full career as a civilian in the Department of the Army. And he worked as a wire chief at the Presidio Army Base in San Francisco. So this is just another one of those photos that I think is really cool. He's kind of just standing out there. He was really breaking barriers, throughout his whole life. And that was one of the things that was really giving me a lot of motivation as a kid, hearing these stories. And the Presidio is where my parents met. My mom was also working for the Department of the Army there. And this is the base here, right at the foot of the Golden Gate Bridge. It's a really beautiful place. If you guys ever get a chance to check it out, I would. So both sides of the family, my grandfather on my mom's side, Brian York, was an infantryman in World War II and Korea and a drill sergeant. So, he had a pretty significant combat experience across those 2 wars as well. And then for those of you who may have heard of Sergeant York, that's he eventually retired as a colonel, but he's known, as Sergeant York. They made a movie about him with Gary Cooper back in the 50s. He's actually my 4th cousin on my mom's side.
That's the guy who got 20.
Yeah, he single-handedly captured 132 Germans.
Yeah. Okay.
Yeah. So yeah, he got the Medal of Honor in World War I. And it's a great story. He was a pacifist, did not want to serve, but he was drafted, kind of forced into it. And he was from the Appalachians. So he's this country boy that was used to hunting squirrels. So he was an excellent marksman, and it translated well into essentially being a sniper in the army. And in the Battle of the Argonne during World War I, his unit was surrounded by a German division, and they were being torn apart basically by machine gun bunkers. And he single-handedly ambushed the bunkers, killed almost 30 Germans by himself, and captured 132 of them and brought them back to the American lines. So he saved all of his men's life in his platoon. It was a pretty amazing story. And let's keep going. I don't want to drag you down too much talking about family history and stuff, but just wanting to paint a picture a little bit of what was my motivation to join. And it's different for everybody, but for me, it wasn't too big of a surprise when I ended up joining the military. I went to military schools throughout a lot of my older education. So middle school on the left, high school in the middle, and then after joining the Marines on the right there. So I served on active duty from 01 to 06. Right after I graduated high school is when September 11th happened, and I was in boot camp on the Yellow Footprints at MCRD San Diego just a few weeks after that. I was deployed to Baghdad and Fallujah in Iraq from 04 to 05. I also served on the Special Purpose Marine Air Ground Task Force that went to Hurricane Katrina for rescue efforts there in 2005 after he came back. And then I served for another 4 years in the reserves and the Guard after that. So my primary unit was the 24th Marine Expeditionary Unit. These are units that are designed to perform quick response missions. Like if an embassy is under threat, we go in and rescue the Americans trapped in the embassy. Or if a pilot goes down behind enemy lines, the MU will go in to retrieve them. That's basically the nature. Also, humanitarian efforts. So like Hurricane Katrina, earthquakes in Haiti, that kind of thing. When the Beirut embassy in Lebanon was having issues, our unit went in to rescue the Americans from there. So that's basically the mission. We conducted operations in this area called the Triangle of Death, which is not the Sunni Triangle. This was a smaller triangle within that area, which is basically bordered by the Euphrates River to the southwest here. And then here's Fallujah, here's Baghdad, and then here's our base of operations right here, Forward Operating Base Kalsu. And during that time, it was pretty violent. There was the deadliest suicide bombing of the war happened just south of us in Al Hilla, where 125 civilians were killed. Operation Phantom Fury, the second battle of Fallujah after the surge, that was the bloodiest battle of the Iraq War. Our unit was involved in that. And we also provided security for the first free elections in Iraq. Our unit unfortunately lost 18 Marines and had another 225 wounded. So it was essentially 1 in 9 of us Here's some photos. That's me in the back of a 7-ton truck there on a convoy. This is us patrolling the streets of the city. I don't think it was actually 145 or 150 here, but the conditions were pretty hot, very dusty. We had when the times we weren't on base, we were kind of camping out, living under a bridge. You know, this was our home, away from home, essentially. We'd have little cots in there, and we would secure the highways. This is MSR Tampa, the main highway that goes through the center of Iraq. So we would create vehicle control points here to kind of secure the area and try to prevent people from moving arms and whatnot through the area. This is me guarding one of the bunkers that we'd set up on either side of these overpasses here for security. And this is one of the local cities that we used to patrol as well. So, you know, it was a tough deployment. It wasn't all bad though. We had some good times. You know, we played a lot of cards. This is my buddy Matt. He found a little stray puppy that you know, probably wasn't the best, you know, like health decision, but you know, he loved that little puppy. He gave him comfort, you know, while we were out there. This is us having a little Christmas dinner here in our chow hall. And these are some local kids that we would see, you know, when we'd be out on patrol. We'd give them candy and food and stuff. That little guy's probably only that happy because he's never tasted an MRE before. I don't think he was that happy later, probably. So one of the things that was tough about this deployment is, you know, we were constantly reminded that we were in danger. Everywhere you look, you know, there was rocket impacts, there were holes blown in our tents. You might recognize this from the previous photo for Christmas dinner. We were sitting right about there, and this is where a rocket propelled grenade came in through the roof and destroyed that section of our chow hall. So, you know, you never knew when and where these kind of attacks were going to happen. There was evidence all over the place, you know, and even this is on base, off base, we were reminded of the same type of carnage, roadside bombs, you know, just destroyed vehicles we'd be dragging back to the base all the time. IEDs, another roadside bomb. 9 of my friends were badly injured in this. That, you know, just shrapnel all over the trucks. This is just something that we just dealt with all the time. So I'm showing you these things because I want you to try to get in the mindset of what it's like to be exposed to these types of stressors over 6 months, 12 months, that kind of thing. One of my friends, Chris Zimney, this was a guy I trained with in San Diego. We were in the same platoon in boot camp, served in the same unit in Iraq, and he was killed by one of those roadside bombs. Super nice guy. You know, we're one of the worst people it could happen to. And, you know, 2 weeks before we went home. So I'm going to show you a video here. It's just to give a little bit more realness to what living in these situations was like. It's not bloody or gory, but I just wanted to give you guys a heads up that it is a little bit emotionally intense. So this is our base here. I already showed you where it was on the map, but it frequently came under attack from small arms, RPGs, mortars, 5 times a week, usually 40 impacts a month. In this specific example, I was caught about 200 meters away from this, where this video was taken. And here's a little bag of some of the shrapnel that almost hit me during this attack. Don't mind the note there. I wrote that as a 21-year-old. So.
Anyone hurt? Oh God! It's all right. It'll pass. Lord, help us get out here. All right. Everyone okay so far? Oh shit! Fucking done yet, chill. Let's get out here, all right? Please, Lord. Please, Lord, let it pass. I'm going to be okay. Oh, Lord, please let it pass. Let us all be okay. Let's all go home safely, Lord. Oh, shit! Holy shit! Hey, chill. Lord, please let it stop. Please let it stop. Shit. Oh God, don't let the next one be any closer. Just let him stop, Lord. Holy, no way! No way! No way! Are you okay? Lord, please let it pass. Please let it pass. No way! No way! Listen to me. Hey, yeah! Allah! Relax, dude. Someone's gonna take your fucking heart.
I think you guys get the picture. It was a stressful time and place, and these are the kind of things that folks are exposed to for long periods of time. You're always, on guard. You never think you're safe. Your cortisol levels are through the roof, and this is the kind of things that people just have to get used to carrying over long periods of time. So I'm going to transition now a little bit to talking about some of these different, ways that things come out later when veterans return home. So PTSD, as I'm sure all of you know, is a mental illness that can arise after typically life-threatening trauma. And these are a normal response to trauma. Symptoms can include flashbacks of the traumatic event. People can become avoidant, try to avoid situations like they don't want to go to fireworks displays during 4th of July because it reminds them of situations like that, things of that nature. They can become depressed, anxious, have anger and hyperarousal, where they, may have insomnia and irritability, paranoia, exaggerated startle response, all of these types of things. And, a major study of 60,000 Iraq and Afghanistan vets showed that about 14% of them screened positive for PTSD, but other studies were rated higher. The estimate is about 500,000 troops between 2003 and 2016 who were diagnosed, in comparison to about 7 to 8% of the general population. Some studies have shown that in women veterans, these rates are even higher. Some think they may be more susceptible to PTSD, experience it more often, and suffer for longer periods of time. Some people have proposed that this could be because of more complex trauma histories that can include sexual assault and things of that nature that happened before the military, and then coming in and putting them through another level of trauma can just be compounding the issues there. There is a disproportionate distribution across branches that's been noticed. The Army tends to have the worst PTSD in comparison to other branches. The Marine Corps is pretty much where you would expect it to be proportionally. And then the Navy and the Air Force are a little bit protected. So I think that this is probably due to the nature of the missions. Being on the ground and face-to-face in these combat situations definitely is different than being on a ship or an air base or flying over the battlefield. But not trying to minimize their service, it's just different. The thing that's different between the Army and the Marines, I think, is probably stigma. I think that the culture of the Marine Corps is very Spartan and you may be perceived as weak if you seek help. It's something that they've been trying to work on, but I think that this is probably not real. PTSD goes hand in hand with substance use disorder often, especially cigarette smoking, even though, maybe we wouldn't think of that substance use, but I think, when you're dealing with AMD patients, it's something to keep in mind that if they have a PTSD diagnosis, it's almost going to double the rate at which they're smoking in comparison to deaths without PTSD diagnosis. A lot of folks have issues with alcohol use and recreational drugs as well, and this has increased pretty much across every war era. It's at its highest now. So I'm going to change gears a little bit and talk about something called moral injury. This is a little bit newer. It's not a part of the DSM, but it is something that's a psychological construct that's been described to extreme and unprecedented life experiences that basically conflict with your own moral compass, moral values. So, you have a trauma, and if you don't have any guilt surrounding that trauma, then okay, no, you don't develop a moral injury. But if you do have guilt and you become avoidant, then you kind of get into this terrible spiral of, guilt, shame, distress, guilt, shame, distress. And a lot of times people end up coping with alcohol and suicidality, they become depressed. There's just a lot of things that have been shown that correspond highly with moral injury. If you aren't avoidant and you kind of sit with the guilt and work your way through it, a lot of times people will, I like the way they put this here, a commitment to reparative action. Maybe you seek a career in medicine to help people. There's just a number of things that people deal with differently here. But this is one of the things that I studied when I was getting my master's. This is just an example, but let's say you're out on patrol and your squad is unaware and you spot a young boy who's around the corner about to ambush you. Do you get the jump on them and save the lives of your squad mates? Or do you follow your moral compass and not engage a child? These are the kind of things that people are faced with on the battlefield that don't fall under necessarily a diagnosis of PTSD. They may not meet the criteria for PTSD, but still are going through significant emotional torment, and it's affecting all the aspects of their lives when they come back. So some folks may say, yeah, you'd be justified in protecting yourselves if they were going to attack you, but it's difficult to live with that. And that's what some of the vets are coming back with. And I don't put this up here to be sarcastic or flippant about saying thank you for your service to veterans. I just want to bring to your attention that not all veterans are proud of their service in the way that others are if they've gone through certain types of experiences. So you have to be a little bit careful about your assumptions when talking to vets about their service. So the National Center for PTSD talks about some of the manifestations. Anomie is an idea that a famous sociologist, Emil Durkheim, came up with that was described as a collapse of personal standards and values. So basically, things have no meaning for you at that point. You kind of withdraw from society, self-condemnation, self-harming behaviors, self-sabotage. These are things that have been noticed with morally injured veterans, and I thought that would lead to them being unlikely to seek help when needed. And that's what my study was based on when I was getting my master's. And I'll just quickly touch on that here in a bit. There's a lot of overlap between PTSD and moral injury, but as far as a lot of the somatic stuff, for sure. But the big buckets you can put them in is kind of like guilt and fear. That's kind of the way I separate it. So looking at healthcare seeking behaviors, one study found that about almost 70% of vets who screened positive for a mental health disorder did not seek treatment. And the RAND Corporation did a study in 2008 that thought about 300,000 vets suffered from PTSD or a major depressive disorder. This number is more like 500,000 now, as you saw on the earlier slide, but this is the most recent thing that I could find with big data. So based on that estimate, there was probably at least 200,000 folks that were kind of falling through the cracks at that time. So my research was called an exploratory analysis of the association between moral injury and mental health care seeking attitudes and behaviors in returning veterans of the Iraq and Afghanistan war. I know it's a mouthful, that's why I threw that photo up there. But the purpose was there an association between moral injury and healthcare seeking attitudes and behaviors, specifically mental health care? And I surveyed about 230 veterans that can view the survey online. They're a little bit overrepresented with women. The military doesn't have a 20% women, but I thought it was good representation overall for that age range. And about 90% of them said they were eligible for VA benefits, but only about 63% were actually using them. And they did have a significant, about half of them had at least a PTSD diagnosis or depression. So we caught a lot of folks that were going through issues, which may have been a little bit lopsided, given that it was a convenient sample. About 12% had been admitted to hospital for psychiatric treatment. So I'm going to skip over the methods and results and stuff because we don't have a lot of time. But basically, when I looked at the associations, and I also measured for PTSD using the PCLM, we found that the associations were higher with those scoring higher with moral injury with not seeking healthcare, with having suicidal ideation, suicide attempts, substance use disorder, pretty much every poor outcome you could measure, it was higher with moral injury than with PTSD. So, basically we need more research looking into moral injury and seeing how much of this is affecting veterans. There was a large, really big study done on Vietnam vets called the NVDRS, the National Vietnam Veterans Readjustment Study, was done in the mid-80s. A paper came out based on that in 91 that showed that combat-related guilt was the most significant predictor for suicide attempts and suicidal ideations. So I think it's kind of a blind spot for the VA right now that needs to start rolling up more veterans in this area. It's being worked on, but we're still a little bit behind the curve, I think. Let's talk about suicide. So this is Chris Greer. He was a friend of mine. We were roommates in Japan, my first duty station. He finished, almost a 10-year career, went home, became a police detective, and next week will be, 7 years since, the day he decided to take his own life and left behind his wife and 3 children. So I'm just using examples of people that I know personally in my life that have gone through, each of these struggles. And I think that is the experience of a lot of veterans from this era. The estimate is about 18 to 22 veterans commit suicide every day in America. The numbers of suicides have far exceeded the number of troops actually killed on the battlefield, a long time ago. That curve started walking away in the early 2000s and has continued to have a larger gap over time. About 20% of all suicides in the US are veterans, even though they only represent about 7% of the population. So it's very lopsided there. And, as you can see here, it's continuing to climb the gap. And with 18 and 24-year-olds being the most affected. Traumatic brain injury. I know I'm kind of going through this quick. We probably need more time to sit on these topics, but I want to make sure I'm covering everything. This is another one of my buddies from my unit in Iraq, Aaron Tam. We served together there, and on one of our convoys, he was standing in the back of a Humvee, unarmored. He was basically in a gun truck and had protection maybe up to his calf or above the knee. And his Humvee ran over a roadside bomb and was blown into the air, flipped over into a riverbank, and he lost large parts of his right arm and left leg. And you would think he would take a seat on the bench at that point, but he went back to school and became an explosives ordnance disposal technician and wanted to prevent other people from suffering that same fate. So he joined a bomb squad basically, and went out and served multiple tours afterwards after a long period of rehab. And during that, he was exposed to another 300 blast events. And this is him on this cover of the National Geographic here on a series on TBI. So he had to be medically retired at age 30. He's in constant pain now. So this is kind of considered the signature injury of the Iraq and Afghanistan wars because of these blast events that people are exposed to. You're exposed to a shock wave, which gives you the immediate physical injury, but then there's a secondary biochemical injury that's believed to happen afterwards. And you saw the videos of what it was like being on those bases. You can imagine being out on the roads with being exposed to these roadside bombs. It was something that was, was very common during those 2 wars. Between 2000 and 2014, there were over 300,000 cases reported, but there isn't a great, means of prevention, treatment, or proven diagnostic criteria. So the military medical school, USU, has a brain injury studies program where they're using autopsy to, find a prevalence essentially in veterans who donated their body to science to look at TBI further. There's a lot of overlapping symptoms, just like moral injury. So biggest things here that, I think of is a lot of neurological issues. So headaches, dizziness, nausea, phonophobia, vision changes, things of that nature. So here are some of the other symptoms that we touched on earlier where there's a bit of overlap. And visual dysfunction is common in veterans with TBI. So some studies have shown up to 90% of folks who have TBI or presumed to have TBI will have some of these issues. So keep that in mind when you're at the VA. You know, if you're unable to structurally explain why someone is experiencing the things they're experiencing, maybe ask them about their blast history, and maybe TBI is something that should be considered on the differential forum. There are some great resources through this Vision Center of Excellence, is run by the Department of Defense, where they have clinical guidelines for folks that are dealing with veterans that may have vision-related issues from TBI. And just a bonus resource I found when I was doing my lit review for this, Brandon Botch has a paper on ocular manifestations of Gulf War illness. It's a little bit more focused on like dry eye and RNFL thinning and other things, but I just wanted to put that out there. It's kind of cool that he was working on veterans health and relating it to ophthalmology there. And this was at Nature too, so pretty cool. So the last thing I'm going to talk about here is depression and homelessness. I think, these are probably large barriers to care. Even, we may see this pop up in the clinic, and it's just something to keep in mind that estimates are wide, but generally accepted about 14% of veterans suffer from depression, which is disproportionate given that they're only about 7% of the population. Homelessness is another thing that affects veterans a lot. There's nearly 50,000 almost veterans living on the street in any given night based on estimates. And it's here close to home too. It disproportionately affects veterans of color and younger veterans. So approximately 40% of homeless veterans are either African American or Hispanic, and 50% of them are between the ages of 18 and 50. Even though this is kind of like one of the smaller portions of veterans in the country. So in summary, some of the final takeaways I come up with, and this isn't evidence-based, this is just based on my own experience. I think that, like I was saying before, don't assume anything regarding a veteran's past service. Feel them out a little bit before, digging into, where did you serve? Were you in combat? Things of that nature. Those are kind of touchy subjects, and you could open up a can of worms that, kind of goes into the second point here, that you have to be prepared for conversations that move away from the eyes. You may need to sit there and screen them for suicidality and depression, substance use, things of that nature, and be aware of the resources that are available to connect them with, like mental health services and social work services. The VA has a lot of great programs that are there to help veterans, but a lot of times they're being underutilized. And I recommend looking at veterans, like any other marginalized or vulnerable population. A lot of these folks are already coming from low socioeconomic status, and then you put a complex trauma history on top of that, and there's just, it's a brutal combination to not seeking the care that they need, or falling through care, or hitting barriers, all the things you can think of when it comes to social determinants. So try to be patient with them. It's the last thing I'll leave you with, because I know they can be a little difficult sometimes. All right, here's some of my references here, and thanks. What questions do you folks have, or discussion points? I know we covered a lot. I know it's kind of probably a little emotional at different points. Yeah, Dr. Larson.
In former soldiers, is their method of suicide different, more violent?
That's a good question. I'm not sure about that. I think a lot of times firearms come into play. Traditionally with males in general, that's more often the route. It tends to be a little bit more violent than than what women usually do when you're talking about weapon of choice or method of choice between suicide. I think that probably veterans by and large would use firearms, but that's my guesstimate. I haven't seen any specific figures on that.
We collaborate a lot with the Minneapolis VA, some funded studies that we did on TBI, and one of the things that came out that they're now pursuing is that, as you can imagine, impulsivity is a really big basic ingredient for what allowed someone to accomplish suicide. And so we're trying to help them identify markers of impulsivity by facial expression, the way they react to special video gaming programs that are gambling like, and then trying to use neuromodulation with direct current combined with the task to reduce impulsivity, because that impulsivity is really, if you can imagine, if you're depressed and you're not impulsive, you're not likely to carry out the task.
Right.
So that's, I think, an emerging issue that people are trying to hone in on, how to prevent impulsivity.
Yeah, that makes a lot of sense.
Yeah.
Cheryl.
So I saw that on one slide, you had this picture of this homeless guy who was like listing all the things that
Yeah. I
was
can
really not
skip
working out for him. And one of the things he said was, I think the VA's, it's actually
This one?
earlier. It's the one where he's like, VA's not helping me, 3-month baby, 17 months sober.
Yeah, I think that was way at the front, yeah.
And so like, we see the veterans that make it to the VA, right? And so I feel like they're always telling me about how happy they are with their care, but then I also hear, not from patients directly, that like veterans sometimes feel like the medical support has not been good. I guess like I'm sure there's data about like the aggregate feeling of veterans on whether or not the medical care given to them after is adequate or good or not, but what's your experience? What's your knowledge of that?
I think it's a very difficult thing to unwrap because there's, you know, like when you look at like the health belief model, it's a lot of, you know, if you're looking at it from a public health perspective, it's like, you know, do these folks think that going to the VA is even going to be helpful to them? I think that that's a big barrier off the bat, because in the military, it's difficult to get medical care in general. I was going to show a little funny video from Instagram. There's a veteran on there that always makes fun of, like, you know, you have to beg, you know, a non-medical person to even allow you to go to the clinic if you're feeling bad, you know, and they're constantly calling you a malingerer. And, you know, it's like so stigmatized to seek help while you're on active duty that I feel like that gets kind of embedded in you when you go back into the civilian world. So you already have that burden on you. And then you feel like the quality of care in the military was so bad, it's going to be just as bad at the VA. It's just an extension of the military. I think a lot of people link those two together. And because just talking to veterans, they're always, you know, going on and on about the VA this and the VA that. You know, I waited so long, and, you know, all they gave me was this. And it's just kind of like a negative point of view more often than not that I hear. I will say those folks that really have needed high level care from the VA usually have a different tone. Like if they needed surgery or hospitalization or, you know, rehab equipment and things, because the VA doesn't really hold back when it comes to expenses on veterans. They provide excellent care and all the services and goods that you would need. But I just feel like the prevailing opinion is it's just as crappy as it was when we were on active duty. Why would I go? You know, like that's the last hospital I'd want to be at, basically. And there's more to it than that. You know, I think it's individualized to a certain extent, but I think that's probably the main reason why people aren't seeking VA services. If you survey them, is just they feel like they may get the same type of treatment that they got when they were on active duty, which usually isn't the greatest. Yeah. Yes, Tina.
Sai, honestly, thank you for sharing. This was just so excellent and eye-opening and really provides for like a deep level of empathy. I think that all the residents who are going to the VA before our rotation starts should like review your presentation, because like you said, it can be challenging, but if you go in with this understanding, like I'm on the verge of tears just thinking about everything you shared. And I was just wondering if you could share with us, like, from your own personal perspective, does it mean anything to you when people say thank you for your service? Should we be very like intentional about saying it often and every time, or is that kind of a flippant thing? And also, what like, I know you gave us our takeaways, be patient,
Yeah.
like, from your viewpoint as someone who has experienced this trauma to some, like, and also is a healthcare provider, what's the, like, best thing is there anything we can, like, from ours, how can we do more or do better, I guess?
Those are great questions. I wanted to put that thank you for your service thing in there just to be the exception to the rule. I think with a very specific experience, some veterans that are very morally injured could potentially have to relive some of those things that they have been avoiding and, for years. If they start thinking about their service, that's kind of where their minds go. And which is kind of why we need different treatment protocols for folks, because in a lot of times with PTSD, it's like exposure therapy and things of that nature, but reliving these terrible experiences that create inner conflict is not necessarily the best thing for someone who's morally injured. So it's case by case. And I don't think that anyone's ever going to be mad about you saying that. It's just that you may be opening up a can of worms, like I was saying before, and I've had it before where, patients at the VA will go down a totally different path and, start crying and really bearing their souls to me in the clinic room. And you just kind of have to sit there. Dr. Oding and I were actually just talking about this recently, about an experience he had like that too. He kind of dropped everything that had to do with the eye exam at that point and just sat there and just tried to give, an empathetic, real connection to the veteran and, just hold their hand and give them a tissue and sit there and listen and be patient, even though the clinic's on fire and there's 8, binders stacking up outside. Sometimes just that extra little bit of time might be the difference that person needed, to make a better decision that day. I don't want to put a lot of stress on you thinking that you say the wrong thing and they're going to go home and do something, but it's just, they are in a lot of ways pretty fragile people, even though they might have a gruff exterior and try to, counteract what they're actually feeling inside, in my experience.
I think that's a really important point. And I've been working over there for almost 34 years, and you can't take your normal way that you do things at the university and port it over there, because it's a balance between, we need to see as many as we can to treat, but we can't overpack the clinic, because you have to engage, I think, with the veterans and make sure that you care for them, not just their eye. And so sometimes that prolongs the exam more. And if you just go through your regular mechanical, thank you for your service, it's kind of like, have a good day. And so you have to kind of, I think, engage with them, that you can't begin to understand what they went through, but you want to help them any way you can. I think they really appreciate that.
I agree. Yeah. I think personalizing it a little bit more, let them know you really appreciate the sacrifice and the decision they made to volunteer to join, to potentially put their lives on the line, Dr. Powell.
Is there like a generational difference in the data you've seen or researched? Because in the eye clinics, when I worked at the VA in my residency, we're seeing mostly folks in their 70s and 80s, of course, who served longer times ago. But the few times when, say, a 30 or 40-year-old came from more recent service, I always kind of worked with this assumption that the moral injury you speak of and the freshness of it would be harder to navigate for them, and more just because of the recency potentially.
Right.
But is that assumption necessarily true? Like, should I be taking for granted that just because this person's older and distance and time from their service has been greater, that it's potentially less of a hot button thing?
I think it's a fair assumption to make, just from my own personal experience, the ability that I have to be able to talk about these experiences and events have matured over time. If we were having this discussion 15 years ago, I wouldn't be able to watch that video and sit there without crying, to be honest with you. I still feel it a little bit, because just the sound is not something you'll ever forget. And being able to put yourself in their shoes, it's like the emotions came back to me, but it gets easier over time. And I think you're right. If you're dealing with a World War II or Korean War veteran, they've got a lot of decades under their belt to process and deal with it. It's probably a little bit self-selected, because the people that lived, they survived it and, you know, moved on that far into their life, they probably weren't dealing with this as, you know, extreme symptoms. You know, I don't think that veteran suicide is something new. I think we're just becoming more aware of it now. You know, I think we're kind of peeling the curtains back a bit more now and being more willing to acknowledge these issues that we're kind of creating, sending our young men and women over into these situations, you know. Yeah, but I agree. I think more, I know we're getting late. It's 8:50.
I just got some
Oh,
chats.
there's somebody in the chat. Okay. Thank you. Thanks, guys. All right.
Thank you.
Thanks, everybody. Yeah.
Thank you.
Oh, thank you. I appreciate it.